Good evening. I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you so much for being with us this evening. On Monday this week, we released the October issue of Health Affairs devoted entirely to the topic of disability and health, our first ever issue focused exclusively on disability. It is groundbreaking for us, and we feel excited to have been able to move health policy scholarship forward. We're a scholarly journal. We attract papers and authors from academic institutions around the world. We have readers, very high-level policy folks at all levels of government. We'll hear from some tonight. And we're trying to advance understanding of the relationship between disability and health. And we feel like this issue is only a start, but a really strong start. So we're so happy to do it. And as we release it, we are also making new efforts this year. You know, we're sort of a DC institution. We would typically have a release event at the press club, and everyone would be in a coat and tie, and it would be all the usual suspects. And we think it's really important to take the work out to where people live and can take advantage of the knowledge and wisdom and use it for practical ends, and that's why we're here tonight. So we're really grateful. I know you'll hear more, but we're really grateful for our hosts here at Main Street. It's great to see it in person, and it's great to support it, maybe more in our heartfelt way than any other way, but to draw attention to the work that's being done here. It meshes so nicely with what we try to accomplish. The real star of tonight is standing to my right, Dr. Webern Watts. He's our Director of Health Equity. He's a health and science journalist. We've had the good fortune to have him with us for a couple of years. He was the Deputy Director in the Division of Diversity and Health Equity at the American Psychiatric Association. His PhD is in pharmacology from Meharry Medical College in Nashville, where I grew up. And he did a postdoc at this small institution up the road called Johns Hopkins in the Division of Cardiology. Vabe, as those who have the good fortune to work with him, call him, Vabe will be our moderator and leader today. So without further ado, I'll turn it over to you.
All right. Thank you so much, Alan. And thank you for hiring me 2 years ago. So I'm able to do this. Hello, everyone. Welcome to Main Street, and welcome to our Health Affairs event that covers our issue on disability and health. I'm really excited to be here today. As you see, we have some state and local leaders who are advocates in really improving disability and health. And so before we actually get into the discussion with our panelists, I would like to go over an overview of tonight's event. We will soon commence with the panel discussion. After the panel discussion, we will show on the screen a premiere of a short film produced as part of our disability and health issue, featuring Judy Human, who is a lifelong disability rights advocate. You really want to see this. She is amazing. And we're just going to pub her book, Being Human, which is an amazing book about her journey to where she is today. So before we jump into the panel, I want to make sure you know all about this incredible and beautiful building that we are in today. And the person who is actually going to talk about this and welcome us to this beautiful building is the chair of the board of Main Street Connect, Jillian Copeland, who, with her husband, Scott, founded Main Street in 2017 and opened its doors in 2020. Jillian has been a member of the Montgomery County community for years, serving as a founder of the Diener School, where she served as head of school from 2007 to 2013, and afterwards as a board of trustee chair and member. Jillian is also a member of the board of directors for the Jewish Foundation for Group Homes, serving on its Disability Inclusion Committee for Greater Washington and its Developmental Disabilities Administration Task Force and the Jubilee Housing Task Force. And as of this year, Jillian also became a member of the inaugural Health Affairs, Accessibility, and Inclusion Committee, where we are striving to really increase accessibility to those who access our journals. So without further ado, I would like to introduce Jillian Copeland.
Thanks. Thanks, babe. I'm going to stand here next to you. Is that okay? So then, hi, everybody. I have to update that resume because a lot of that isn't happening, but thanks for including me in Health Affairs. Now I have something to add, which is really great. I'm so happy to be here. I'm so grateful to Health Affairs. Thank you for including Main Street in the conversation, but more importantly, understanding this important intersection between disability and health. It's huge. As many of you know, many people with special needs or some kind of disability, there is a strong comorbidity with other health impairments. But people with disabilities are often left out of the conversation. I'm not really sure why, but you guys are certainly moving that needle and allowing the disability to be part of the narrative, and that's really essential. So thank you all, Alan and your team and Vabe and Patty and everybody. You guys were amazing to work with. I also have to a huge shout out to Stacy Watson, who's here. She hates when I do this, but I don't care. And she's our director of membership experience. Her dad's right next to her. And this is an important topic for her. And she introduced us, which is great. I'm going to do just a really quick, this is Evan, by the way. He's our new director of communications at Main Street, or communications associate. I don't know, whatever the title is. Welcome to Evan. This is your 4th week, right? Yeah, so he's a newbie. So make him feel welcome, please. I'm so happy to be standing up here with all of these amazing people. Most of you I have worked with at some point, but I appreciate so much what you do for our community and am grateful for your service. So thank you for being here tonight and for all you do. And just a quick show of hands. Anybody know what Main Street is, what we do? Yay. Okay, yay. That's good. It's sort of like all around, but not in the middle. So I'm gonna focus on you guys a little bit, and I'm going to be really quick. Main Street is 3 things. Main Street is a lot of things, but I'm going to just boil it down to 3 things, which is not easy for me to do. If you know me, brevity is not my friend, but I'm trying. So this is our first. It's an apartment building. There are 70 units above us, and 75% of this building is affordable. 25% of this building, of all of the units, were set aside for adults with disabilities. Currently, we have 52 people 52 out of 150 that live at Main Street, reside here, that self-identify, or their parents have identified them as having a disability, right? So it's really a really different type of model. Sadly, it's a really different type of model. But we're really pushing the living because people with disabilities don't often have an opportunity to live independently. And there are lots of reasons, but mainly because they're not accessible apartments, they're not affordable is the key. And even when they do have an apartment somewhere else, it's not inclusive. And that's a big thing for people to be included as a part of community and have a place and a space of belonging. So the room that you're in now is Poppy Boy's Kitchen. And we do all kinds of fun things in here. And then the other spaces are designed so that not just residents of Main Street, but community members who join our membership or even who just come to Main Street can be a part of our programming. We offer 22 programs a week, everything from culture to music to food to, Sisha, give me a program. What's your favorite program here?
I would have to say is just to create one-on-one friendships, especially for every friendship across Montgomery County.
Okay, well, that's awesome. So our social events, we have just lots of different, thanks, Sisha, lots of different programs that we offer here every week. 39 people that live in the building are members of Main Street, but we have 250 members. So lots of people in and out, coming to find a place and a space to belong and connect and, move their bodies and stimulate their minds. And so it's just really an amazing place to be. So you don't have to live here to be a member, right, Stace? you can come in anytime and join us, and we welcome you. So please check out our calendar when you leave, look at what Main Street is doing, and come be a part of this amazing place. I promise you will leave with a smile, because I do almost every day, even through the hard work. The third part of Main Street, and then I'm going to be done, I promise, is moving the inclusion needle forward. And that's a really big thing for us. And we do it by modeling what should be expected for really all people. Any people that are in need, any people that live in a margin, anybody that is in a marginalized community, everybody has value, everybody has so many beautiful things about them, and this is just a place where we see people, we hear people, regardless of age, stage, disability, background, and we're trying to model that for the rest of the community. Also, education and awareness through conferences and research and disseminating that research. And so living is a huge piece, programming and being involved in community, and then moving inclusion forward so that we have a kinder, gentler, more dignified, respectful world to live in. And so those are really the goals of Main Street. They're big, but we're moving the needle, and we hope you guys will join us. So I think this is just a start. And so thank you for letting me share Main Street, and thank you all for being here tonight.
Thank you. Thank you so much, Jillian, and for inviting us to come back to Main Street. I'm actually going to start this Sunday with some Sunday football going on, because this place is very, very, very comfortable. It's a beautiful building. Now, as we transition along to our panel discussion, I would like to introduce to you some people that we have, very important people, who we have on our panel today. Tonight, we are joined by Secretary Carol Beatty, Secretary of the Maryland Department of Disabilities. Ms. Stacy Herman, the Assistant Vice President of Neurodiversity and Community Workforce Development at Kennedy Krieger Institute. Dr. Odile Brunetto, the Chief of Aging and Disability Services at the Montgomery County Department of Health and Human Services. Dr. James Bridgers, Jr., the Acting Chief Health Officer at the Montgomery County Department of Health and Human Services and the Chief of the Public Health Services. Councilmember Gabe Albornoz, Montgomery Council Member at Large, who currently serves as the Council President for the Montgomery County Health and Human Services Committee and the member of the Public Safety Committee. And lastly, we have Councilmember Craig Rice, who is a Montgomery Council member who currently serves as the Council Chair of Education and the Culture Committee and sits on the Health and Human Services Committee. Welcome all. To kick us off, I would like to give every panelist an opportunity to spend 90 seconds to 2 minutes answering this question. What are your current priorities for addressing unmet needs of the disability community in Montgomery County and/or the state of Maryland? And we're going to start with you, Secretary.
Okay. And that was a really tough one to kind of narrow down all the priorities that, as a department, we tackle every day. But I think the one that I wanted to bring up here was, and it's because we've heard this over and over again from family members of young adults with disabilities, is that transition in medical care from pediatrics to adult medicine. And obviously we know the reasons why. Many of our young folks have complex medical needs. That's a tough transition to go from a trusted medical professional or specialist to somebody new. And sometimes those specialties are not as well represented in the adult medicine world. Also, there's confusion about who pays for what and insurance. And, it's just that trade-off of here's my child, and I'm going to have to start a whole new process with them. And so, it's a number of things, but it's what brought to our attention the need to add a fifth guiding principle to the state disability plan that would focus around health and wellness.
Thank you. Ms. Herman?
Thank you. Thank you for having me this evening. So under our Neurodiversity at Work program at Kennedy Krieger Institute, we are really focusing on improving employment outcomes and community engagement for individuals with disabilities through a multifaceted approach and thinking about it through collective impact. So bringing together collaborators across the state, across the nation, focusing on common goals and coming up with solutions to these challenges. In addition, Kennedy Krieger Institute is a healthcare organization. So we do provide supports and services to individuals with disabilities across varying disabilities and services, including a focus in the past year and will continue on the COVID-19 vaccine, hosting a clinic providing a comfortable and safe experience for individuals and their families to access the vaccine, and thinking about mental health and the impacts that has on the disability community, along with what Secretary Beatty said, transitioning medical care and that transition from from student and child to adulthood, and really thinking about how can we continue that care.
Thank you. Dr. Brunetta?
Sure. Thank you again for this opportunity. First, I wanted to put things in perspective. Per the U.S. Census, 12.7% of U.S. residents disclose that they do have a disability, that is self-disclosure. So for Montgomery County, we have 86,000 persons who live in the county of all ages. And so about 50% of them are people over the age of 65. So you can see the spread is across all ages. And in my department, we clearly work with babies, young babies, infants and toddlers, all the way to people who are 100 and plus. A big area for us is unemployment for young people who transition out of the schools, all the way to people who would like to work, even in their 60s. The unemployment for persons with disabilities is close to 12%, as compared to less than 4% in the general population. Another huge area has to do with wait list. We have so many wait lists for county programs, state programs. Some of them are so gigantic that I don't even dare to talk about the number of people on those wait lists. For some people, you're going to have to wait 5+ years in order to receive a service. So that is really very challenging. Also very challenging is the ability to identify young babies who do not have a developmental process that is smooth, and they need to be identified as early as possible, as early as 18 months old, in order for them to be able to receive intervention. And those early interventions are so critical and so helpful. Another area for us also has to do with access to healthcare, and I'm sure everybody's going to talk about that. Accessing a physician who understands, who takes more time to discuss issues. Dental care is also very difficult to access. Specialty care. So that is an area where we all have to do much better work. There is also regretfully a lot of issues with diabetes in all population, and so we need also to pay attention to prevention of diabetes if it's possible, and then intervention when the diagnosis has occurred. And so there is also one terrific, very problematic issue is staff shortages in all areas of services, county government, nonprofits, all sectors. And so trying to hire staff who are going to be there when a person needs personal care, any support, that is really a challenge. So
Thank you so much. And some of these issues that you were talking about is actually covered in this issue.
Okay.
So they really go into detail at different levels about what Dr. Brunetto discussed. Dr. Bridgers.
Sure. So just a couple of points, and thank you for inviting me this evening. In meetings, Dr. Brunetto and I literally sit together. That's the affinity that we've grown over, or we've come together to grow over the past couple of years. So we talked about access. We talk about transportation. We talk about cultural barriers. We learned a lot over the past 2.5 years in responding to testing and vaccinations and access in congregate spaces, and that was a challenge. But one of the things that got us through those barriers was community engagement, town halls, conversations like this, working with our county council to look at the policies and the regulatory challenges, and to work through that to get a better understanding. One of the enablers, I like to say, is that we grew to have a better understanding of cultural competencies. We talk about healthcare workers, but having those healthcare workers supporting our needs, and then community engagement. Our community partners were instrumental. Our Minority Health Initiative partners were very instrumental in us getting out into the community. We knew that we couldn't do the work under the HHS umbrella in the office. We had front-facing staff and individuals coming to us, but we really needed to go out. So we work with our aging and disability services to reach our homebound individual. I remember sitting in a meeting with Councilmember Rice, and he raised the question as whether or not we'd reached out to our non-governmental organizations such as Family, Food and Family, or Family and Friends. And so we started to expand our safety net, if you will, to gain more insight. We learned many hard lessons over the past couple of years, and we realized that we needed to do more. We still need to do more. So we've convened a work group to talk about transportation barriers from community stakeholders, because we want to hear the feedback. We want the information. We want to be able to inform and present to our legislative body those policies and regulatory challenges that we face so that they can help us. So those are some of the things that I can readily call to mind, but I know Dr. Renetta helped us instrumentally. When we needed to go out into our developmental disability spaces, we had to staff strike teams because we knew that in certain settings we couldn't go in with a lot of people. It had to be very comfortable and culturally appropriate. We knew that those individuals had language barriers, mobility barriers, visual impairments, hearing impairments, and we didn't see those as deficits, but we looked at those as being strengths. How could we leverage the strength in this community to better serve and support them? So those are some of the things that we did, and thinking back over the past couple of years, how we could increase, and it doesn't stop there. We continue along that spectrum. So we look at the services across the lifespan, from infants to our seniors. And so we know that it's necessary, it's needed, and we have to be more responsive. And so we look to strengthen that ability as we work together. We had to integrate. We had to integrate our services. We could not operate in a silo. It wasn't just public health and what public health was doing to inform the process and the outcomes. We had to look to our aging and disability services, our children, youth, and families. We had to look at HHS inclusive to provide a holistic response.
Thank you so much, Dr. Bridgers. Councilmember Albanos.
Thank you, Dr. Watts. What an honor to be on this panel. I feel like Craig and I are bringing up the rear here. Right? Some really extraordinary leaders in this space. And I think there's so much to say, but I'll try to process this in a way that can be digested, because it's difficult to digest. But as policymakers, our job is to make sure that we put the thought leaders who are working hard in this space in the best position to be successful, to give them the resources that they need, to give them the policies that they need in order for us to be able to meet the needs of the community. And it is so appropriate that we are hosting this here at Main Street, because Jillian, and the first time I took a tour of this place, my jaw dropped. This should not be the exception. This needs to be the rule. We need to look at every policy and every line item through a disability and inclusion lens. And that starts with places like this, where we have thought leaders who had the vision, the personal connections within the community, and the wherewithal to get this off the ground. This is a movement. And this is what we need to have extended across the entire county. So But I'll focus on a few specific policy areas that I in particular am interested in uplifting. And I do think workforce development is a critical one. WorkSource Montgomery is the county agency that is tasked most directly with providing employment programming and services and training, but they can't do it by themselves. We have to ensure and incentivize our private sector as well as our nonprofit sector to acknowledge the record number of vacancies that we have across the board can be filled by these extraordinary individuals that have skills that we would all benefit from. And not just those skills, but by the very nature of us including them in this work tells an important message about our community. And it's the kind of community I want to raise my family in. So that is critically important. A second issue which hasn't been touched on yet, I am the proud son of immigrants from South America. And while there are extraordinary wait lists, and we have to address those wait lists by creating more capacity, the problem is even more grave in our multicultural and multi-ethnic communities, especially our Black and brown communities, who either don't know about or don't have the wherewithal to be able to access the programs or the knowledge that they are supposed to be receiving services within our various not just our school system, but our government infrastructure and construct across the board. They deserve these resources, but they don't know about them. And so we have to be more intentional about meeting the community where they are, which leads me to my final point. And it was touched on earlier as well, but early detection and making sure that our medical providers and our healthcare providers have the staff and the training and the expertise to be able to diagnose, but to be able to provide support for families from day one. We have to eliminate some of the stigma that unfortunately still exists. So there's much more we need to do, but those are some of the highlights that I think will make a difference.
Thank you. Councilmember Rice.
Well, there's nothing left at this point. I mean, it's actually really interesting because I want to try and tie in all of these things together, because the reality is this, is that during COVID, what we realized was that so many people in our disabilities community experienced what everyone else experienced during COVID. The isolation, the disconnect to health services, the challenges when it came to employment, all the things that everyone else experienced and saw during COVID is what our disability community experienced pre-COVID, and especially for our kids. When we talk about the isolation, as chair of the Education and Culture Committee, when we talk about our kids and the toll, right, that everyone says that they saw their parents, saw in their kids, that it took on them from being disconnected from their friends, well, that's what the parents of disabled children experience, and children who have differing abilities experience each and every day. That's what they have all the time. They are the ones who are isolated on the playground. They are the ones who don't get invited to the birthday parties. They're the ones who are separated. And so that same feeling that all of these parents who said that my child suffered during this event, I hope that they just take a step back and think about that that is actually what the parents of children with disabilities experience each and every day. And so it is something that makes us realize how it is that we need to change our system. And it really is incorporating, as you've heard from everyone, into ensuring that folks are woven into the fabric that is Montgomery County, understanding that there is no space where there should not be a space for people, right? At your office, on the playground, on a football team, whatever the case may be. And see, I come from a different background because my mother taught at Model Secondary School for the Deaf and Gallaudet University, so I grew up in that special education space. So all I knew was inclusion and how important that was. But the reality is that that does not still exist, because when this is the rarity, when this place is not the norm, we still have so much more work to do. When we have places like Longview that are great in terms of incorporating right on Matsunaga's campus in Germantown, incorporating schools together where you have children with high intensity developmental disabilities and physical challenges right there alongside other children, learning together. But that's not the norm. and we have to make that the norm if we are truly to be an inclusive community.
Thank you so much. You know, it's amazing to have all of you in these positions to really make change and like really impact lives and really promote inclusion within everyone. So I just want to say thank you for working on these priorities. Thank you. I'm going to go with the first question, and I'm going to start with Dr. Brunetto. Okay. And so the question is, how is Montgomery County adapting to trends towards home and community-based care rather than institutional care? And what challenges do these shifts present to Montgomery County, and what solutions are you pursuing in response?
Great. Thank you so much. So obviously, many of you know that way back when, persons with disabilities were segregated in institutions. And in the state of Maryland, we are happy that that is no longer the case. We have closed the institutions some way back, thank goodness. Yeah, when I first started with the county in 1988, they were in the process, the state was in the process at that time of closing the institutions. So the good news is that people are living in the community. But in order to do that successfully and safely, people need supports. And for the developmental disability community, the supports come from mostly the Medicaid program, which is a state federal program. And the Medicaid rates are not very satisfactory in order to be able to provide services that are very costly. So what we have done for that population, thanks to the work of the county council and previous county council and previous county executive for many years, it's something that I don't think exists anywhere else in the state of Maryland. We are providing $20 million a year for the providers who serve our disability community in group homes, in their own homes, on the jobs. So we clearly have a terrific commitment to make sure that we help the best we can so that people have quality service and adequate staffing. We also have other persons with disability who would, in the old days, be in a nursing home. And we have other program that is called a medical adult daycare. This is for adults 18 and over, and so we have 13 nonprofit and for-profit providers in the county, and they provide a safe and stimulating and nourishing and loving environment during the day, Monday through Friday, for persons who are older, again, 18 and older, who are not safe to stay home by themselves during the day. And so when you go visit the program, and I know some of you have gone, and I know you are on the cheerleading group there, you can see the interactions between the staff and the participants, among the participants themselves. They have access to a nurse there all day long. They have all kinds of activities. They go on outings when the weather permits. It's just a wonderful place. So what we also are doing, understanding that these programs are funded mostly by Medicaid, and the Medicaid rate is not very good, the county is also helping the providers in the medical adult daycare space. So this year we are helping them with $2.1 million. So another thing that we are doing, of course, is knowing that a lot of persons who need long-term care reside in nursing homes and in assisted living facilities. And we have had in the past an agreement with the state whereby our friends in public health, under the licensing and regulation program, where we had an agreement with the state whereby the state delegated to our local staff the ability to go in nursing homes and investigate when there was concerns, problems. Regretfully, that agreement stopped 2 years ago, and we are in a point where we don't have this partnership any longer. Mm-hmm. So we have that issue as one of the number one priorities on our radar screen to work, of course, with our council, with our state delegation, and our state partners over there. And then everybody talked about staffing shortages. We have established a workforce, a local workforce here, in partnership with Workforce Montgomery, Montgomery College, Montgomery Public Schools, to look at encouraging young students who are in high school to possibly have internships with providers, nonprofits, for-profits, who need the workforce, so that the youngsters would be interested, motivated to have summer jobs, etc., and possibly consider a career in those areas. Another piece is I talked about some of those long wait lists. The Maryland Department of Health, in partnership with the governor's office and the General Assembly, realized that those wait lists are really unacceptable, and they have a plan over the next couple of years to start releasing some quote-unquote slots to reach out to the folks on the wait list. So when a person is identified as possibly becoming eligible for a Medicaid program, first they need to have an evaluation by a nurse, by a county nurse. So the county nurse goes into the person's home, evaluate, send the information to the state for the state to decide yes or no, etc. So we are, waiting to receive the names of those folks who are going to be released on the wait list, and then in turn it will increase our workload, and again, staff shortages. We are going to need to hire more nurses, and it's just sort of like a circle. So okay. I will leave it at that.
Okay, so keeping on the subject of the work of the Montgomery County Health and Human Services, Dr. Bridgers.
Yes.
How does the Montgomery County HHS work with other governmental agencies to address issues of disability and health? Could you share any examples of recent initiatives that stretch across agencies?
Sure. Great question, Dr. Watts. So, as Dr. Brunetto said, we've worked collaboratively with our Department of Permit and Services to look at those regulatory challenges that we have, and we're going to work through that because we know that we need to keep our congregate spaces safe for all. That's just the bottom line for us, and working not only with the county leadership, looking at our Montgomery County Department of Transportation. I mentioned earlier in my opening comments, we've called together a work group to look at transportation barriers and to increase access and inclusion. Council President Albornoz and Councilmember Rice talked about that as well. So we want to break down those barriers so that individuals can get to the specialty care that they need. And so we need to assess, we need to take a deeper dive, and we know that under the HHS umbrella, we can't do it alone. So we need our governmental partners, our county level partners. We've even extended to those non-governmental partners. We've worked with our Medical Reserve Corps to look at those individuals that we could bring in to support the efforts. We know that within the Medical Reserve Corps, we have doctors and other clinicians that would help augment some of the services and staff as we visit congregate spaces. We looked at early on the Department of General Services when we didn't have a lot of PPE, personal protective equipment. So we got more PPE in working with them, but we also knew that various communities required various levels of PPE. So a KN95 may not work for someone who has autism. And so we work with our community providers and our other parents who are also doctors themselves, and we listen to them. And so those are some of the things that we continue to do and assess our ability to provide more appropriate services. And then lastly, we work with our community partners. I mean, I cannot overemphasize the impact and strength that our community partners help us keep the pulse, our pulse, and the services and our responsiveness to our developmental disability community, because without them, we couldn't do a lot of the work that we currently do.
Thank you. And on the subject of partnerships, I'm going to go to Secretary Beatty for this next question. You know, you've worked in the non-profit advocacy organization in state government. how can state government work with nonprofits and community organizations to collectively meet the needs of the state disability community?
Well, thank you for that question. And again, I didn't get to say this, and I should have. Thank you for having me here today. It's really an honor to be part of this panel and to share this information and to hear the great things that are happening in Montgomery County. But anyway, so I want to tell you the story about the Maryland Department of Disabilities, because I do believe that this is a way, a model for the rest of the nation to bring together different groups and different state agencies and different local municipalities and different local governments to work together around these issues that are very complex, and we can't solve them on our own. The Department of Disabilities was created in 2004, and it is the only cross-disability policy cabinet-level department in the United States. Right. Which really, when you think about it, it means that I am at the table as a governor's appointed position. I am at the table with all the other cabinet secretaries. And when you talk about cabinet departments that serve people with disabilities, every department, it's within county government, within state government, everyone touches the lives of somebody with disabilities when you talk about the percentages of people with disabilities in our state. And so we have found that it has been really important to have that voice at the table. And the other unique thing about our department is that in our statute, it requires the secretary or the deputy secretary to have a disability, because representation matters. Mm-hmm. And authentic conversation matters. And so it's really, I think we set this up the right way in 2004. And actually, we've had a couple of states recently reach out and wonder, especially during the COVID pandemic, how they might do something similar in their own states. But it is our job to bring together the partners, the voices. First, the voices of the person with the disability and their families, and then the people around them that serve and support them. And that's what our department does. So when you talk about how to do it, that's what our mission is. And so our role is to bring together all these voices, as I said, and to create the most well-informed and efficient and effective public policy as it relates to people with disabilities. And I could give you a number of things that happened during the COVID pandemic, but I wanted to focus on a non-COVID example of what our department did in the last couple of years. Prior to the pandemic, we were reached out by a few disabled advocates in the community. One was from Montgomery County. I don't know if you know Josh Basil, the incredible Josh Basil, but he came to us with a number of other disabled folks and said, we are participating in the Employed Individuals with Disabilities program. It's called the EID program, or it's better known as kind of the Medicaid buy-in program. And it allows people who are employed who have disabilities to buy into Medicaid, which is so important when you think not only the health insurance is so incredibly important, but it also the support services that are paid for through Medicaid help people to maintain themselves in their community and on their job. And they were asking us to help them think through wanting to expand eligibility for people with disabilities who have higher income levels, and also to revise the counting of spousal income and investment income. To put it bluntly, to stay in this program prevented people from getting married, and having families. Yeah. And it just, their case was compelling, and we brought it to the Department of Health, who oversees this program, and the leadership there thought the argument was compelling and created a work group, and we brought all the players together. And the long story short, because it did take a while since the COVID got in the middle of this, but in the last budget cycle, we as a state made the revisions, not all of them, but many of the revisions that this advocacy group had wanted to have, so that now people can marry, they can exclude their spousal income, and they can also exclude some of their retirement savings, helping them to build a future, a more stable financial future. That's what our department does, and I would recommend that, and I think that that happens within county governments as well. And I love working with Montgomery County. They've been great to work with through the pandemic and whatever. It's just, I think it's bringing those voices together.
That is progress. Thank you for working on that. Ms. Herman, your work is focused on community workforce development. How is workforce participation of people with disabilities connected to community participation and overall well-being for people with disabilities?
Thank you. So sitting on this panel, I am the only one, I think, not in elected official or in we're in healthcare, but not working for the state. And I am able to bring the lens of an adult service provider. You've heard that mentioned many times. So one of the programs I actually designed, implemented, and now I oversee at Kennedy Krieger Institute is Core Foundations. And that is an adult service provider that works with individuals with disabilities, their families, their support team on employment or meaningful engagement within their community. We support them in their journey. And I'm going to tell you a story about a young adult. 5 years ago, I'm going to use he and I'm going to say autism because those are his preferred when telling this story. He was in his second to last year of school in high school, and he learned about Project Search. And Project Search at Kennedy Krieger Institute and programs across the entire state, including 3 in Montgomery County, are a transition to work program, oftentimes in your last year of school. So he applied to be in the program. In his last year of school, he was accepted into Project Search, and he attended during his last year of school. After that program, he was then accepted into Core Foundations at Kennedy Krieger Institute, which continue to provide him long-term supports to meet his ultimate goal of wanting employment within his community. With the support of amazing direct support professionals and the team at Core, he obtained a job within 6 months of graduating from Project Search. Not only a job, but a dream job in retail. We are now, yes, but even more that is exciting is that we are now almost 4 years later, he has retained that job. He has actually retained it through the pandemic. He was furloughed for 6 weeks only. They had brought him back quickly, and he also increases his hours. He gets called in. And what is even better is the relationship between Core Foundations and his employment and this young adult, because we have to work collaboratively as we are thinking about how do we support when there's a challenge at work? Because many employers, when there's a challenge, that can be an impact or a loss of job for a young adult or an adult who is employed. But if we have a collaboration and we are working together on strategies and supports, and there's education and understanding of those modifications and knowing that a provider agency is there to provide that support, then retention can happen. An individual can maintain that job, but it takes support. And I really liked what you were talking about inclusion. You're thinking about it's got to be woven into our community, but the community has to change. Individuals with disabilities are part of that community, and that our community needs to think differently. Our businesses need to think differently. Our businesses need to be educated on how to be inclusive of all abilities within the workplace, but also thinking about the direct support workforce. I don't want to leave them out because they are extremely valued, and they're the, when we think about our organizations, they are the most important people in that organization. They are day in and day out working with individuals with disabilities to help that person obtain their goals. And that position needs to be valued and deserves the dignity of that position. And we need to realize how important that position really is with our wonderful policymakers that are here. And thinking about how can we retain our current direct support workforce? How do we increase it? How do we educate and train? And then how do we continue to educate and train our businesses? And at Kennedy Krieger Institute, we do that. We go out to businesses. We provide training on inclusive workplaces. But I want to take you back to that young man's story about going through the Project Search program, getting supports from his agency and his family and himself, right? Successfully obtaining employment. It's not just, we're just that support, is that is no different than anybody else who does not identify as having a disability. They're in school, maybe they get an internship, maybe they go to college, and then who helps obtain jobs? Mentors, professors, parents, everyone has a team around them. So I think it's really important to recognize that we shouldn't see this as different. It's just everyone has their own support team. It's not different because this person has a disability. It's the same within our workplace. We all provide our own supports and accommodations in the workplace for ourselves, or you have supports and accommodations supported through your manager, or you need some help, and that's provided to you. We shouldn't think and look at it any differently that a person with a disability needs some types of modification and supports to really be able to be successful in their job. And I do think with long-term research and policy change and looking at our funding and services so that our direct support workforce is really being provided and valued for what they do, we can really be successful in Montgomery County and Maryland as a whole.
Great.
Thank you. You know, you talked about support. You mentioned different types of support, including education. So I ask Councilmember Price, you are the chair of the Education and Cultural Committee. What are the educational needs of people with disabilities in Montgomery County, especially around health, well-being, and care?
So, you know, it's interesting. I brought up the model of the Longview School that's with Matsunaga Elementary School as a prime example because it was very formative for my children as they went through school. Growing up in a family where we talked about differing abilities was incredibly important, but for them to experience it and understand was one thing. But there was also the conversation around what the expectations and support were for those individual children that were necessary for them to overcome some of the obstacles and challenges that they face. The reality is that just as we just heard, they may be different from others, but they're not different in terms of what it is that we need to do. You heard from my colleague that a person who's an immigrant who's coming to this country for the first time, learning English as a second language, will need support to be able to navigate the language, understand the new culture that they're in, and to be able to assimilate themselves to the community that they find themselves in. Why do we hold a person with differing abilities any different in that same sort of mindset or conversation? It's very interesting because it is something to where you said our society has to change in terms of our perception of what it is that a person with differing abilities is. Because their mind operates differently, or maybe they have a physical, thing that's about them that's different, but the reality is that they're still a human being. And so they have the same wants and loves and likes, and so we need to treat them in that education space accordingly. I don't believe in the true separation of individuals and saying that because you are a little bit different from someone else, that therefore we're going to put you in a separate space. That doesn't make sense, and I don't think that's conducive, nor is it conducive to those individuals who are there who then don't get to experience people who are not exactly like them. It is not supportive. I saw a gentleman as I was walking from Starbucks who was a double amputee. 20 years ago, me seeing that gentleman with a double amputee would have been very different about my perceptions of him than they are now. And we all know that to be true, right? We've seen so much that has happened in terms of us really understanding why. It's not because anything has changed about that individual that's the double amputee. The double amputee from now is the same double amputee from 30 years ago. The reality is our perception has changed, that we do understand that that person can run marathons, that that person can be in the workplace and do whatever the case may be. And there are no differences that are associated with that. We've done a great job of making that happen. But here's the difference. What we still have not done is made sure that they are truly in the fabric in terms of our workforce, because we don't have teachers with differing abilities and disabilities in our classroom. And I will tell you something, that if you truly are one who talks about inclusion, it has to be there as well, because the same conversation that we in the Black community have about the fact that having a Black male teacher has a huge impact on Black, especially young Black males, but all Black students in terms of their success. It's very interesting. My daughter, for the first time, she's taking ASL 2, has a deaf teacher. But it's a first. It's a first. And so it's very interesting to think that, well, why not? Why would you not have a deaf teacher teaching ASL in the high school classroom? It just makes sense. But it's something to where we thought in our society, in our community, that that wasn't good enough, right? There was something wrong with, and so it wasn't good enough to have someone teach. And until we change that, and we have to be intentional about making those changes, we'll continue to have the challenges that we face. And so I think that we find ourselves at a crossroads now, right? And that's in the workforce in general, but especially in our school system, to where we see our children who present to us with these needs. And my good friend gave about early detection. When I served on the Kerwin Commission in the state of Maryland, early detection is a key part of now the blueprint in making sure that we can early identify those children that may have differing abilities so that we can give them the support that they need, understanding that it's not just about educational support, but it's also about the physical, emotional, mental health support as well. Because just as we've seen discrimination that happens against and people present with PTSD who have been discriminated against, our children with differing abilities are experiencing the same things. We just haven't diagnosed them with that before, but now we're starting to realize that those are the cases. Imagine the day in and day out and term out the torment that exists when we talk about a kid who's overweight, right? And we talk about that, and we talk about the angst and the pain that that person experienced, and it's true. So imagine a child who's got Down syndrome, who has autism, and who occasionally, yells out in the classroom, and the torment that they're experiencing as well. And so they then recess and don't want to be involved and engaged. How is that child going to be successful in school? And so we're measuring, assuming that there's something wrong with that child, when in reality, we should be treating that child for the mental challenges that they're facing via their mental health, because they've been bullied and stymied in their educational growth, not because they can't function, not because they can't do the work, but because they're constantly living in fear and in anguish and in hurt and in pain. And so when we look at the Be Well 365 campaign that is a part of MCPS now, and I'm sorry, I know I'm over, but this is really important, just to wrap up, it really is about looking at the holistic part of the child, of every child, not identifying one as a person who identifies with having differing abilities or a disability, or one who's different ethnicity or gender identity or any of those kinds of things. Every single child deserves to be able to have a pathway that leads to their happiness, love, and success. It's what we owe to our kids, and it's what we need to do within our education system to ensure that we have a better community. So.
Exactly. Thank you. And just everything you said, inclusion. Thank you. Inclusion is definitely the thing, and there's various aspects of inclusion. And so my last question is for Councilmember Albornoz. How can the county make sure that efforts to support the disability communities are culturally competent and culturally sensitive?
Yeah, so great question, and there's been a few mic drops here. Those were really important messages. I do want to elaborate on one thing. This, unfortunately, is Craig Rice's last year on the council because he is term limited. But one of the things that he has done and championed, which I think has a direct correlation to our disability community, is the vocational training programs within MCPS. And I think that that is a huge opportunity in the next evolution of our vocational training programs to help develop skills necessary to employ people immediately after high school. And college is not quite a right fit for anybody. And so, or for all people, I should say. And so I think that that's another area where I think, and I'm going to carry that torch because I do think that there's some real investments that we can make. Yes, I will.
Yeah.
I will.
It's on
Check, please. No. So, but that is absolutely right. But I think in terms of multicultural, the first is we need to empower and train the connectors. The people in our community, whether it's community-based organizations, community leaders, faith-based organizations, people that have some level of trust within communities that have an expanded voice. Sometimes it's policymakers, but more often it's the tia that lives on the corner that is who you go to find out where to get a job or where to get some level of service. Those are the folks that we have to connect with and empower. So we followed a very similar model during the pandemic. We made a huge investment in health promotores across the entire county, and we flooded the zone. We were in Home Depots, we were in mega marts, we were in soccer fields and parks, we were in malls, movie theaters. We went everywhere to spread the message about the importance of vaccinations and to dispel some of the challenging and incorrect information that was out in the community. We need to have the same level of urgency in reaching families whose children are suffering in the way that Craig articulated so well, and that need services that they absolutely have the ability to access but just don't know exist. And it's more than just translating pamphlets into different languages. That's important, but that is like the floor, because we really do have to make sure that there's a cultural competency and empower the entire staff and not just have one or two people be responsible for cultural competency. It needs to be infused within the overall culture of all organizations. And then finally, I think we need to uplift families that have benefited from these programs and services as ambassadors themselves. So the other day, we've heard testimony before the council from remarkable individuals who have testified on various issues, and they're doing it not as a person with a disability, they're doing it as a resident of our community. And I think that that's the other thing. If we can empower some of these families to be engaged, to join boards, to join commissions, I think that'll make a difference too.
Amazing. You know what? That was our last question. Please give our panelists a round of applause for all the great work that they are doing to really improve disability and health. We sort of ran out of time for the audience questions, but that is okay. We are now going to prepare to view the Judith Heumann video from Health Affairs. And as we prepare for that video, our panelists will still be here, so you can actually go up to them and ask them the questions. And we're just going to move out the way. But thank you again. Give our panelists a round of applause. Thank you so much for coming to Health Affairs today.
Hello, I'm Vabren Watts, Health Affairs Director of Health Equity. The October 22 issue focuses on disability and health. According to the CDC, 1 in 4 U.S. adults live with a disability. People living with disabilities have historically been denied the fundamental access to elements of life, including housing, education, as well as healthcare. The issue notes that while federal civil rights laws have prohibited discrimination against people living with disabilities, many barriers still exist, resulting in disparities and inequities. Despite this reality, the past 50 years have brought about many changes to our legal landscape. These changes have happened due to many people, including the woman that we will hear from today, Judith Heumann. The daughter of Holocaust survivors, Judy was stricken with polio as a child, leaving her wheelchair-bound and quadriplegic. Her parents were told to institutionalize her, but they resisted and got her admitted into elementary school. They instilled in their daughter a seed of activism, which sparked her remarkable career as a disability rights leader. Recently, October issue's theme advisors, Lisa Iazzoni and Javier Robles, spoke with Judy about her remarkable career and the work that lies ahead to achieve health equity for people living with disabilities. Here's some of that conversation.
As you stated in your book, Being Human, when you were a young girl, you had a child ask you, "Are you sick?" which was, I guess, a question that shocked you to some extent. Can you tell us what the difference is between being sick and being a person with a disability?
So that's the adult question, and then there was the child's reaction. So for me, when I was 8 and this young boy came up to me and said, "Are you sick?" it was a recognition that I wasn't invisible. And it's not that I ever thought I was invisible, but I was the only person that I knew at that point in my life who was a wheelchair user. I had met some people when I was 4, when I went to the Rescue Rehab Center. But outside of that, we didn't see people like myself in children's books or on TV or in cartoons or comics or any place.
Do you think that since the time you were asked that question to today, that children view disabilities differently than they did maybe in the past, that there's maybe some growth, at least in that area?
I mean, I would say there is some more awareness, but not anywhere near what I think all three of us would believe should have happened by today. I think younger children or kids 8, 10, 12 are also beginning to ask the question of why don't we know this when they're reading books like Rolling Warrior, my book, which was geared towards young adults. They, like college students, high school students, are really asking the question of why don't we know this? Why is it not being included in what we're learning in school? So that's very important. Yes, there is more awareness, but not yet anywhere near as much as there should be.
From the early 1970s to late 1970s, you were really active in kind of promulgating legislation and regulations to increase access for people with disabilities, specifically Section 504 of the 1973 Rehabilitation Act. Can you tell us a little bit about what life was like for people with disability before these federal laws went into effect, culminating with the 1990 Americans with Disabilities Act?
Yes, and I thank you for the question. So I think I'm going to talk a little bit both about the 70s and until the ADA, because what is important for people to realize is the laws that we saw coming into being started in 1978. No, sorry. The law started in 1968 when Hugh Gallagher was able to get an amendment on a piece of legislation that required that any federal money being used for curbs, for sidewalk construction, have curb cuts. And that, I believe, is kind of the first piece of legislation which really at the federal level was addressing the issue of access. In the 70s, what we really started seeing in the 60s was the emergence of disabled student services offices. And I think they were quite important. There weren't huge numbers of them at that time, but University of Illinois, University of Chicago, UC Berkeley, Long Island University, NYU, Brooklyn College, I'm sure some up in Massachusetts also, were beginning to form these groups. And the groups were really being formulated, one, because the schools were lacking accessibility, helping students to register for classes, helping blind students get the books they needed, helping with those kinds of accommodations. And what we were learning as we found out about each other is talking much more about not only what was going on the college campus, but issues that we had of concern relating to what would go on after you left the college campus, on employment, on personal assistance services, whatever it might be. Likewise, in the 70s, what we started to see also was the development of the movement of people with mental health disabilities. That was really very important because the voices of people with psychosocial disabilities were beginning to come forward. And likewise, the self-advocacy movement of people with intellectual and developmental disabilities was slowly beginning to emerge. I mean, the reality is in the 1970s, as the disability rights movement was emerging, the college students and others, none of us had really been involved in lobbying. Most of us had never been involved in development of legislation, in meeting with legislators or doing anything like that. So you really saw a lot of things that were going on that were allowing people to begin to understand the potential power that we had and the need for us to be able to articulate not only what the problems were, but what the solutions were. You also see people that were learning from other movements. So the civil rights movement, I think, was quite influential for many people for many different reasons. The women's movement, the anti-war movement, all these things were influential. So between the late 1960s and 1980, you've got this development of the independent living movement, centers for independent living starting in Massachusetts, 11 of them coming up in California, Michigan. So people really coming together and talking. So we were really learning and networking and reaching out to legal aid and many other places. And I think one of the biggest issues that many people know about, not as many as I would like, is what happened when the 504 regulations were not signed. I think that really was a major point in the disability rights movement, not just in the 70s, but still through today, because it was a relatively small group of people representing a large group of people. And it wasn't just disabled people, it was also coalition development. When President Carter was elected and he committed to having these rules for Section 504 signed because President Nixon and Ford refused to do so. And when his administration was dragging their feet, that's when ACCD really very quickly, like a couple of months after the election, came in and started organizing around the country. Because I think we really saw a moment in time that we needed to get these regulations signed because of the process that had been going on for over 5 years. But equally importantly, I think we were really recognizing that it was important for us to be able to affirmatively show that we had the ability to really make something meaningfully happen. And then, of course, it really was the birth of the ADA, because we knew that 504 didn't cover anything in the private sector. So when shopping malls were being constructed, when movie theaters were being constructed, restaurants, people could still be discriminated against if they didn't live in a state where there was a law that said you couldn't throw somebody out because they were disgusting and displeasing to look at. So it's been a momentum, and the work that had to go on with the Americans with Disabilities Act was in part predicated on the success of what had happened with 504. But I think one of the important parts of the Americans with Disabilities Act is very much that we were able to really, on a state-by-state level, get House members and senators to recognize that discrimination wasn't something that occurred once in a while. and it didn't only occur in certain places. So it really is, I think, a merging of so many things that it's important to really put it in the full context.
So how do you think that historically attitudes about people with disabilities have changed, specifically in the healthcare system?
So, I have my master's in public health from Berkeley, so I look at public health and healthcare as part of a whole, but when I talk about society and the changes that have gone on in society, I think implementation of laws like 504 and the Americans with Disabilities Act have been breaking down many different barriers. I would say in the physical environment, we probably have seen the most changes, but I think when you look at like unemployment rates of disabled people, we still see such a disproportionate number of disabled people in the world of work. And I think that really cuts to, again, positive things that are going on. Groups like Disability In and National Organization on Disability, Job Accommodations Network, and many others that are focusing on bringing people together to learn about what they're doing, what they can do more. EEOC and the Justice Department and others doing a better job of enforcement. I think one of the positive aspects of what's going on when looking at healthcare specifically is when we look at COVID, clearly COVID was an example of what the health industry was looking at doing if you had a disability and then had COVID. I think what was very important was the fact that organizations like the protection advocacies at the state level, the Disability Rights Education and Defense Fund, and the policy work that's been done over the last 30, 40 years was such that we were able to prevent certain policies that would have been enacted from coming forward. I think when we look at the healthcare industry itself, we also have to look at it in relationship to the society as a whole. And obviously, the Obama administration, the work that they did in the area with the ACA, very important. I think the disability community played a critical role in not allowing the conservatives to roll back the ACA as much as they wanted to. I also found it very interesting to look at efforts that ADAPT, for example, were moving forward with when these various amendments were coming forward, sitting in members' offices, having demonstrations, and how you now began to see people without disabilities or people maybe with disabilities that hadn't been identifying as people with disabilities coming forward and speaking up and speaking out in a way that I think people hadn't done before. So we may be at a place right now where there is more coalescing going on between people in the United States who have various healthcare needs that may be temporary or permanent, maybe a disability or not, in really looking at the value of healthcare. I mean, because healthcare is a complicated issue in the area of disability. I think, as we all know, most doctors' offices are not equipped to be able to have someone, for example, with a physical disability be able to come into their office and get appropriate services, and likewise for people who have mental health disability, intellectual disabilities, other forms of disabilities. So many people, healthcare providers, have not been appropriately trained in even providing the most basic health care. And so I would say the system itself, while moving forward, in part because of laws that are being more enforced, that are requiring things to happen, the healthcare community as an industry has a lot further to go. I think there's value in the fact that 504, for example, is enabling, or one of the results is more disabled people being able to get into healthcare professions when they previously were denied the right to get into healthcare professions based on disability, not based on qualifications. But even there, that's going very slowly.
Judy, from my perspective, perhaps the seminal Supreme Court ruling under the Americans with Disabilities Act was the 1999 Olmstead ruling, that where basically the late Justice Ruth Bader Ginsburg wrote that people with disability have the constitutional right to live in the community rather than an institution if that's what they want to do. However, we know that providing the personal assistance services to allow people to live in the community is really, really hard. This issue of health affairs talks about how hard it especially is in rural areas. I would like to hear your thoughts about 1999 Olmstead and whether you think that it is really true that people with disability get the supports that they need to live in their homes and communities.
Well, obviously, the Olmstead decision, which was written by Judge Ginsburg, was a pivotal piece of court rulings that really have resulted in reinforcing what people had been saying for decades. And what I'm seeing as a user is a dwindling force of people who are available and interested in doing this type of work. I think too frequently many legislators don't really understand the positive impact of having something like personal assistance can be not only on the individual to live outside of an institution, but also to be able to participate in the community, including in work. So we have a lot further to go in this regard. One, for me, I also think we need to be looking a lot more at the issue of immigration reform, because we've got dreamers in the United States, 9, 10, 11 million dreamers who, some of whom would be interested in doing this type of work and other work, professional positions, but they can't get legal status to work. So I think that is a very critical issue that also has to be worked on.
You mentioned about 10 minutes ago in your wonderful colloquy about healthcare that there are very few people with disabilities being educated to become healthcare professionals, especially doctors. And I just wondered if you could expand on that a little bit and talk a little bit about what you perceive as the barriers that are currently preventing people with disabilities from entering healthcare professions.
I don't have the answer, I have thoughts. Some of my thoughts are that, for a while, I think before COVID, there were a series of ads that were on television and many other places, reaching out to young girls, teenagers, regarding STEM. And they had young women who came from every background. I never saw a single visibly disabled young woman in any of those ads. The absence of highlighting disabled people with visible disabilities and people with invisible disabilities by being able to interview people who have whatever their invisible disability may be means that we still are living in the legacy of not seeing ourselves.
Judy, one of the things that we have seen in the last few years, of course, which has affected pretty much every person in the U.S. and in the world, is the COVID-19 pandemic. And in some instances, it has affected individuals with disabilities a lot more, in a more drastic way, as you've seen. And it's also shown that society, to some extent, was not prepared for this pandemic. I know people with disabilities were not prepared for this pandemic, but we have had to deal with it. How do you think that this pandemic is going to affect disability rights from here on in, after so many people that were not disabled initially got to some extent experience disability?
It goes without saying that the United States and most other countries were not prepared for this pandemic, nor do I believe that we've necessarily learned what we need to learn skipping disability about what to do when future situations like this happen. What does it mean to be prepared, and what are we being prepared for? Things that we're seeing as a result of COVID are vaccination rates in other areas for children going down. And what is that going to mean in the future if children are not appropriately vaccinated for illnesses that previously had been almost wiped out? I also think, though, that the disability community in some very real way has learned about the direction that the healthcare community would go in if left to its own, and why it's been very important to have organizations like the Disability Rights Education and Defense Fund, the American Association of People with Disabilities, the National Disability Rights Network, which represents protection and advocacy agencies around the country, and how the bringing together of legal rights and human rights and a stronger disability community and getting the media more involved really, I think help prevent further catastrophes. But when we look at the numbers of people who died with disabilities, I think one of the other issues is that people who died as a result of having COVID plus diabetes plus hypertension, as an example, people weren't discussing diabetes or hypertension as a disability. They were just words that were being put out there. In the disability community, and we were able to come in and look and say, these are disabled individuals who were being underserved before, and as a result came in with more healthcare disparities and were at greater risk of dying from COVID, because they also were not getting appropriate services in the community, obviously. And really, I think the public health system needs to be speaking up much more loudly about what is happening in trying to make people in our country feel that government does not represent them and not holding government responsible.
But what else can we do in the healthcare system to make sure that they get the assistance they need? So, God forbid we have another pandemic, we're not experiencing the same things in these communities.
I mean, I don't think these are quick fixes. First of all, we need more disabled individuals of color, from the LGBT community, and also that healthcare providers who come from different racial backgrounds, sexual orientations, they need to also be understanding disability. They understand the link between poverty and disability in many cases, but we need to make sure that people are getting the appropriate preventative health care that they need. It's also people from the Latino community and the Black community, Asian community, on and on, understanding that there are high-risk people within their communities that they may or may not define as having a disability, but do have these comorbidities that people need to understand and really need to be paying much more attention to. It's looking at the public health care system in a community, the local public health hospitals, and talking to disabled people and healthcare providers in the local communities to understand what the gaps are and what needs to be done. I think these are the areas that we need to be focusing on. And disability across the board is still not being looked at in a way that it needs to. And I think that's partly driven by our not having enough power within these different professions.
Thank you all for joining us. Thank you for being part of a conversation and helping us bring the material to this incredible community with the people who came to talk about the wonderful work being done. Most of all, I really want to thank our Main Street hosts for making this such a lovely space for us for one evening, but for so many people for much more than this one evening. It really shines through. And here we go. I want to acknowledge our producers who do cat. I'm not going to read all the names, but Many of them are in the room, and they just worked so hard to make this what it is. So we have a lot more. We, of course, have the issue, which is available at no charge. We have Journal Club, where we'll go deep into a particular topic. We had a release event on Monday. It's recorded if you missed it. We also have other events, including a Policy Spotlight interview with Dave Chokshi, the former commissioner of the New York City Department of Health and Mental Hygiene. You won't want to miss that as well. Hopefully, we've brought a few new people into our community. You'll come look at the website and see what else we have to offer. Again, thank you so much for being with us tonight, and thanks particularly to Dr. Vabe for leading us through that great discussion.